Welcome to the Davies use case webinar being presented by Memorial Hermann on identification of sepsis, the effect of an automated screening tool. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer reviewed to validate sustainable improved patient business outcomes resulting from health information technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's call, Siraj Anwar. Siraj, I'll turn the presentation over to you. Thank you.
All right, thank you, Arnold, for that introduction. Greetings, everyone. My name is Siraj Anwar. I'm the Associate Chief Medical Information Officer for the Memorial Hermann Health System, and I'm here today to present our HIMSS Davies case study for 2018, which is the effect of an automated screening tool on the identification of sepsis. A little bit about our healthcare system. We are located in the Houston metropolitan area. We have a total of 14 hospitals. That includes 11 acute, 2 rehab, and 1 orthopedic specialty hospital. From our network of care perspective, as I said, we serve the Houston metropolitan area and have close to 300 care delivery sites ranging from acute care hospitals to imaging centers to joint centers. For us at Memorial Hermann, quality is always a competitive advantage for us. As you can see here from the list of the awards and recognitions that we have, most of them are focused around quality. The most recent and notable of which is the HIMSS Davies Award from 2017. So jumping into the sepsis screening process, so a little bit of a background with some numbers. I'm sure that we can all agree that sepsis is an important piece of the healthcare puzzle. According to the CDC, more than 1.5 million people get sepsis each year in the U.S., and out of those people, about 250,000 of them die. That's essentially 1 in 3 patients who die in a hospital who have sepsis. And when you look at the total spend for sepsis in the U.S., according to the Sepsis Alliance, in 2013, we spent $24 billion. That's billion with a capital B. This slide says it all. No one is immune to sepsis, not even Superman. Christopher Reeve died because of sepsis due to a systemic infection resulting from a pressure wound, which is a very common complication of folks living with paralysis. Part of the complexity of sepsis is that this broad syndrome encompasses diverse presentations, such as a newborn in the neonatal intensive care unit with a Group B streptococcal bloodstream infection, or a 7-year-old who is hospitalized with severe influenza. Or it even could be a 60-year-old undergoing chemotherapy for lymphoma who acquires mucositis and multi-drug resistant gram-negative broad bacteremia. Or it could be an 80-year-old with severe pneumonia without an identified pathogen. So what can we do for our patients? Well, step 1, it's important to identify when our patients have sepsis. Looking for the signs and symptoms is key, and it could present itself in different stages. First, you have the SIRS, or it's commonly referred to as the systemic inflammatory response syndrome, or it could present at a later stage in the form of severe sepsis. And if you take it even one step further, it could present in the form of septic shock. Step 2, once identified, timely evaluation and treatment is key to survival. This comprises of diagnostics to confirm sepsis and treatment with fluids and antibiotics and other supportive treatment. I may have oversimplified this just a little bit because there's a lot more that happens to appropriately treat and manage sepsis. Looking at the evolution of the identification and treatment of sepsis, and this is according to the Surviving Sepsis campaign, we've gone through 3 different phases. Phase 1, which was the use of paper-based forms that provided the necessary information needed for sepsis screening as well as the treatment plan. Phase 2, which I had the opportunity to live through here at Memorial Hermann, and as we converted to our EHR, was the use of electronic forms for documentation, which created some level of automation for the identification of sepsis, but it still required the user to put the pieces of vital information together. And then phase 3, which is currently where we're at, uses advanced clinical decision support tools that help in automating the process for early identification of sepsis, as well as providing a treatment plan. To ensure that we were using technology appropriately within the clinical workflow, we incorporated a governance model that initially started with the CDS Oversight Committee. And the CDS Oversight Committee was responsible for overseeing the implementation of clinical decision support in our system. That's what CDS stands for. But as the scope of work broadened, we had created a standalone sepsis steering committee. And then, as an organization, when we decided to make sepsis a system-wide initiative, the Sepsis Joint Operating Council was created. The common theme of governance was that we had all of the clinical stakeholders at the table as we designed and implemented the clinical processes to manage sepsis. We had physicians, nurses, pharmacists, lab, infection control, pretty much everyone that is engaged in taking care of the patients. As we continue to evolve as an organization, we now have our clinical practice subcommittees, or CPCs as they're called, for critical care, managing all of the governance processes for all things related to sepsis. Now, part of this governance process required us to make several key decisions, and I've listed out some of those key decisions. The first one was whether we were going to use a screening tool or not, what the criteria would be within the screening tool, and what the criteria would be for SEERS versus sepsis. How would we notify our clinicians that the patient has SEERS or sepsis? And then what are the treatment modalities and monitoring modalities that would be available to our clinicians when these patients were identified? And then finally, we wanted to have a good governance model over how we measured our processes and our outcomes to define success or to identify success. This is a screenshot of the screening power form. It has 3 main fields. One is for the documentation of SEERS. The second field is documenting the suspected source of infection, and then the third field was for documenting the organ dysfunction. So this is what field 1 looked like. It was required for the nurse to document this. On the right, we actually had the last set of results within the past 24 hours that were available to the nursing staff around vital signs, labs, and mental status that would help them to answer the form appropriately. The second field, suspected source of infection, would only show up as required once the first field was completed. And then field 3 was the documentation of the organ dysfunction, as I mentioned. And each of these fields has a scoring that is running in the background, and those 3 boxes in the bottom would get filled with a score based on what was being documented. So in 2013, we had a new technology that was made available to us by our vendor, and it used cloud technology or cloud computing to help with identification of sepsis, patients with sepsis or SEERS. And the way that this architecture worked was it had what is called a crawler, which essentially goes through our database and crawls through the different data points within the patient's chart and it takes that data and sends it up to a cloud which has an algorithm for detection of SIRS and sepsis. And once that algorithm is run, if any of the criteria is met for SIRS or sepsis, the cloud sends back a trigger to our database so that we can use those triggers to decide what we want to do within the EHR. So to look at the differences in identification of SIRS or sepsis between the screening form, manual screening form versus the sepsis cloud, we actually ran them simultaneously. We continued with the process of the documentation as well as looking at the St. John Sepsis. That is the actual name of the product that our vendor has provided for us for detection of sepsis. And so the St. John Sepsis agent was also run at the same time, and we audited charts for a week, and we identified 28 patients within the ICU. And what we found was that with the manual screening process, 2 positive screenings were found for severe sepsis, and that resulted in 1 patient moving to a higher level of care. But when you look at the St. John Sepsis agent, that resulted in 11 alerts for sepsis, which resulted in 5 patients moving to a higher level of care. So one of the other things that we did was we also looked at the comparison of the total screening forms that were completed and which patients met the criteria. And what we saw was, this is data for just 1 day. If you look at the total number of screenings that were completed, that was 2,814. And it takes about an average time of a minute for the nursing staff to complete that form. So that's 2,814 minutes in 1 day for our nurses to complete the tool. The screening tool also picked up just 13% of the total number of potential sepsis patients that were picked up by the St. John Sepsis agent. Albeit it's important to note that there were some patients that were identified by the cloud that may not have been septic patients. So the tool has adjustable trigger ranges for both the SIRS alert and the severe sepsis alert, and these ranges can be refined to adjust for sensitivity, and we control this. There were several workflow considerations that we needed to make once those triggers came back to us from the St. John Sepsis agent. And so in this example, I actually have a screenshot of the messages that we were sending to pager messages or to cell phones. These were being sent primarily to the areas of our hospital where rapid response team had coverage. Some other workflow considerations on the left, you'll see for our inpatient settings, we actually sent a nursing task that showed whether the patient met criteria for SIRS or sepsis, as well as showing an icon on the patient access list. On the top right, in our ED, we have a tracking board, so we posted icons on the tracking board to help identify those patients who had those alert firings. So a yellow S indicated a SIRS alert, a red S indicated a severe sepsis alert, and then if the S was green, that was an indication that the MD, the physician, was already notified. In the bottom right, this is a process that we recently implemented for our OR staff. So when a patient goes for a procedure and they meet criteria for sepsis or SIRS, the tasks were firing to the floor. And since the patient was not on the floor, no one could do anything with it. So we saw that as a gap, a potential gap in the care that was being provided to our patient. So we implemented this notification to fire to the OR staff if the patient's criteria was met for SIRS or sepsis while they were going through the procedure. Once the task or icon or the notification showed up to the nursing staff, when the nursing staff clicks on it, they have the ability to document what they're doing with that information. It also shows them what criteria was met for either SIRS or sepsis, as well as documenting the outcome. So did they notify the physician? And if they notified the physician, did they receive new orders or not? And if the physician didn't do anything with that information, did the nurse feel that there was a need for escalation through the chain of command? So they have the ability to document all of that. We also created order sets And to build these order sets, we used our existing order set editorial board, which is our governing body for all things related to the order sets. We appointed subject matter experts to help us build the content. We also brought in different representation from the facilities to obtain consensus on that main content. We did do a system-wide rollout, and we review the content periodically and update accordingly as the evidence changes. These are some screenshots of the order sets that we have. This one is an ED sepsis order set. It has all of the different classifications of orders, and then from the antibiotics perspective, we've actually created subsets of those medications depending on the source of infection. And since majority of our patients come in through the ED, but we may also have patients who are identified to have sepsis on the floor. We also have a floor sepsis MPP that is built in a very similar manner and has the antibiotics created as subsets based on the source of infection. One of the measures that CMS introduced for sepsis was around the ordering of repeat lactate. And so what we did was we actually automated the process of ordering the repeat lactate based on the criteria that was assigned by CMS. And when this repeat lactate is automatically ordered, it actually has notations in the bottom that lets the user know that it was automatically ordered, and it also tells them to not cancel because this patient may have severe sepsis, and that's why we're doing this repeat lactate. So moving into functional measures, these are measures that help us to understand if the sepsis screening cloud is working, because there's always a possibility of the cloud going down. And are alerts and notifications working? Do we understand how often they're firing, and are we at a risk of over-alerting? So to help us to identify if the sepsis cloud was going down, we created a downtime identification process that actually that looked at the incoming triggers from the cloud into our system. And what we found was that there was a certain threshold that we found based on historic data that every 30 minutes, if the number of triggers went below that threshold, there was a good chance that the cloud was down. So this is done in 30-minute increments, and the arrow actually points out to an area on this line graph that shows that the number of triggers went below 25 in a 30-minute time frame, and that is when the cloud actually went down. And we have a method of communication to communicate with our vendor and to our clinical staff that the cloud is down and that the sepsis screening process or identification process is not working, and that the clinical staff should be mindful of their process for identification of these patients. I talked about the notifications or alerts to the OR staff while the patient is in the procedural area. We turned this on recently, and when we looked at the alert data, it looked like, the alerts were firing pretty often. And when we dug deeper, what we found out was that these notifications were firing to nursing staff who had established a relationship with the patient. Not for the current encounter, but it's a lifetime relationship. And so we actually went in and turned off that relationship or expired it on a specific date, after which you will see that the total number of notifications and alerts dropped significantly. And the reason we were able to do this and identify this was because we were tracking the data closely. This shows a daily rule firing trend for the repeat lactate. You'll see there's a consistent trend in the number of alert firings, no significant dips or significant increases, so we know that the rule is working as it should be. And jumping into process measures, we wanted to understand how our clinicians were responding to the alerts and notifications and how they were using all of the tools that we had implemented for identification and treatment of sepsis, and whether the care that was being provided to our patients was being done in a timely manner. And so to help with that, we created this scorecard that shows the process measures associated with the nursing staff communicating to the physician, and it also allows us to capture data around what the nurse did with the notification and how timely they made that notification. So a green is they notified the physician in an hour or less. Yellow is 1 to 2 hours, and red is more than 2 hours, or it was not done at all. And so the nurse managers who have responsibility over their respective nursing units can take this information and start to identify where the problem areas are and provide that feedback either to the nursing staff or to the physician. I talked about the repeat lactate. This was actually the inverse. The lower fallouts of not doing a repeat lactate is a better measure. So after we turn on the repeat lactate rule, you'll see our numbers drop significantly. We also have process measures around the utilization of sepsis order sets for our patients who are diagnosed with sepsis at discharge. This is actually a dashboard that we've created that is shared with the facilities. They have the ability to look at their respective facility data and identify which physicians may not be using the order sets and providing that feedback. A green arrow next to the percentage indicates that there's an upward trend. Most of our facilities do have an upward trend because we are doing a lot of focused education around the use of order sets across our organization. So looking at outcome measures, this is for the mortality rate. A lot of the downward trend previous to turning our sepsis alert on is attributed to the focused attention that we as an organization decided to take on several years ago with sepsis. We incorporated a lot of the manual processes, including that manual screening form in the EHR that I talked about, but we've been able to sustain that decrease over the years, and with the sepsis alert implementation and the process surrounding it, we have continued to reduce that mortality rate. And when you look at the average length of stay as well, you'll see we've had a downward trend over several years, but that trend continues to go down with the implementation of the sepsis alert and its surrounding processes. So when you look at what this means for our patients and for us as an organization, as a result of the improvement in the mortality rate and the average length of stay for our patients with sepsis, we've saved 8,836 lives and have saved 346 hospital days. So that's 631 lives saved on an average every year, or approximately 2 patients each day. And with that, I've actually come to the end of the presentation. Thank you for your attention.
Thank you, Suraj, for joining us today and presenting your Davies use case for Memorial Hermann. We want to remind folks where to go find this recording and other great Davies use cases and information on how to apply for Davies. That information can be found at the HIMSS Davies Award website at hims.org/Davies. Again, that's hims.org/Davies. So thank you so much and have a good day.